Excellencies, Honorable Ministers of Health from the respective member states of the SADC region, esteemed delegates to the 5th Africa CDC Regional Ministerial Steering Committee meeting for Southern Africa. Ladies and gentlemen, good morning. As is very, very customary, we like asking or greeting you twice just to confirm that you are with us. So good morning. Very good. It is indeed a pleasure to be here with all of you this morning and to welcome you to the second day of the ReSCO meeting. We had extremely productive and fruitful discussions during the first day yesterday. We were graced by the presence of Her Excellency Dr. Netumbo Nandi-Ndaitwah, President of the Republic of Namibia, represented by Honorable Ambassador Dr. Kaire Mbwende, Director General of the National Planning Commission, who delivered powerful remarks from Her Excellency the President, setting the tone for the 5th ReSCO meeting. We were also graced by the presence of His Excellency Dr. Jean Kaseya, Director General of the Africa CDC, as well as Dr. Tedros Ghebreyesus, Director General of the World Health Organization. We discussed many, many matters relating to public health security and health financing, not just in the Southern African region, but also within the African region broadly. And so today, we wish to continue with those rich and fruitful discussions. I have the honor and pleasure to invite to the podium Honorable Ndudzu Matsebula, Minister of Health of Eswatini, who will be chairing the 5th session and the first session of today, Building a Stronger Southern African Region, Scaling National Health Insurance and Regional Health Security. Ladies and gentlemen, please help me warmly welcome Honorable Minister from Eswatini with a round of applause.
Honorable Ministers, Excellencies, distinguished guests and all participants, all protocol observed, good morning. You are all looking beautiful and fresh. It looks like I'm the only one who slept after 5 a.m. We really had a good time yesterday. And please put your hands together for the host minister and her team. Thank you so much, Minister, for taking good care of us. My name is Mduduzi Mlondi Matsebula from Eswatini, as introduced. I've been directed to facilitate session 5. So welcome to the 5th ReSCO meeting, day 2, session 5, which is all about building a stronger Southern Africa region, scaling national health insurance and regional health security. Ministers and participants, you will note that we are at different levels of the NHI implementation as reflected yesterday. And the whole purpose of this session is to share experiences and learn so that we use the regional best practices to our advantage as we implement NHI in our different countries. And Zambia has over 2,900 public facilities along private and faith-based providers, and we value their contribution in the region. And I'm honored to introduce the Director General of the Zambia National Health Insurance Management Authority, who is going to deliver the strategic expert presentation on expanding national health insurance as a catalyst for universal health coverage, and share Zambia's success story from establishment to implementation, highlighting all the hurdles that they went through to achieve the NHI. So please put your hands together for Dr. Michael Japau, the Director General, as we welcome him to the floor.
Thank you very much. The Chair, thank you for the opportunity, and Your Excellencies, the Honorable Ministers from our countries in the Southern region. Let me simply say, all protocol observed. Thank you. As you're aware, we are coming from Chair, just to break a little bit of small ice, we've just re-elected our president. So you can give us and we elected him with a sweeping vote over the whole country. Thank you very much. Your Excellencies, the Chair, it's a privilege for us from Zambia to share the presentation today. And thank you to CDC Africa. We had you the whole of yesterday to understand that the national health insurance schemes are probably, if not one of the most important goals that you have put as one way to help with the domestic financing and promote the health sovereignty we have been talking about. So we are here to showcase the Zambian experience. It has not been easy. The hurdles have been many, but we are here to show that it can be done, and it has been done. We have been running for at least 6 years now as a scheme, successfully, and still going. And I'm sure 6 years is a reasonable experience. Even ourselves, we are still learning how to manage it. So thank you, Chair. Our presentation, that's the outline of our presentation. We'll be talking about the background, the rationale and key design features, the implementation model that we have, because we realize that even health insurance schemes have different models in some of the countries that we have seen. We're going to talk about the NHIS coverage and success for the last 6 years at least, and obviously the implementation challenges that we have gained. So our scheme, Chair, is established by an act of Parliament as a health financing to complement, this is very important, to complement the general tax revenue that goes into the health sector, and to help finance the health sector by adding to the already existing mechanism that comes from the taxes. To do this, there are 5 things we do. That is, 1, to provide financial risk protection from catastrophic and impoverishing health. You have to excuse me, I'm not seeing this where I am properly. I need some help. Either to move this a bit or that. Yeah, just a bit. Better. Thank you. So, Chair, I was saying to do this, there are 5 things. 1 is providing financial risk protection from catastrophic and impoverishing health expenditure. And the idea is to cut out out-of-pocket. Out-of-pocket payments for healthcare services. That is the whole idea. Number 2, ensuring the availability of funds to the health sector for improved service provision every time, because that's the challenge we face. People may have money, but when you have faced with illnesses, you are not sure whether you'll have money all the time, especially for the citizenry. Enhance equity in accessing to health services by expanding provision of insured health services to all citizens, which is the equity objective. We heard yesterday from our Honorable Minister from South Africa, and our goal is to build that, to avoid that kind of situation and build an equitable service that is available to all citizens. Harnessing private sector participation in the provision of healthcare services. The private sector is important, and we carry them along, especially the private sector in the health facilities. We carry them along even as we provide our service. So our members receive services from both the public sector and the private sector. So all that put together, the National Health Insurance Scheme, from the Zambia perspective, is the vehicle that we have created to drive the agenda for universal health coverage, where all individuals and communities receive the health services they need without suffering financial hardship or looking for money when they are sick. The rationale is to drive revenue mobilization, to mobilize revenue, finances, and make those finances available, again, as I said, as additional revenue to the health system. Number 2, pulling the revenue together, providing a more systematic way of pulling funds together or pulling revenues together so that these revenues are also available. That helps us because we receive the revenue in advance, we can invest it and grow the fund so that it can also, on top of the collections we receive, it can be available to help pay facilities, pay the claims whenever they are required. Strategic purchasing of health services, that is the reforming the financing of healthcare services from the input-based to output-based. Reduce out-of-pocket payments and achieve equity in access for all. I talked about this. And lastly, reduce foreign health assistance dependency. And obviously, this is something that has been talked about very often. So we think that the health insurance mechanism is another vehicle that will help us to reduce on our foreign dependency. Obviously, that's the long-term plan. What are the key design principles of the scheme from the Zambia perspective? Number one, it's a mandatory scheme. All citizens and residents that live in Zambia are obliged to register and contribute. So it's mandatory, Chair, and distinguished citizens, but a person ought to register or to be registered. And that's the only way we can save you, because you must be registered. Number two, it's premised on the social solidarity basis. So the social solidarity principle is that the rich contribute together with the poor. The young contribute together with the old. The haves contribute together with those haves by a way of proportion of your income, or by the way of your earnings. But all individuals access the same package of services in the same way. Because we are driven by the principle that at the time when people are sick, they are human beings. And so, since they are human beings, we will not say this one requires a heart pacemaker, this one, because he's poor, he doesn't need it. So it's driven and premised on the principle of social security. Then there is cross-subsidization. Cross-subsidization based on the one above. The wealthy subsidize the poor, the health subsidize the sick, and the young subsidize the old. The older we get, the more illnesses come, and so the contributions or premiums paid by the young people help subsidize the old. Equity in contributions. The NHI, or our scheme, contributions are based on ability to pay through a percentage of earnings. The sick do not pay more due to their illness than the healthy. Just because someone is on oncology or on cancer doesn't mean they should now pay more than the ones that are healthier. So they all pay according to the same calculations that we have already put on the system. So equity in access. Access to health services is based on healthy needs. So the main thrust is that access is driven by healthy needs, by the need of the individual on their health, irrespective of the level of contribution they have made. Chair and distinguished guests, we have a benefits package which we have designed in Zambia, and that benefits package is the menu for the health services we offer. The benefits package we have is quite a wide and generous one, very wide. It covers secondary and tertiary services. Services are portable. What do we mean by portable? You can receive the NEMA services from anywhere in the country as long as you're a member, from any facility in the country. As long as you are within the borders of Zambia, you can receive the NEMA facilities. Obviously, all our facilities are what we call accredited. So all the facilities in the country, so we have accredited the facilities all over the country where our members can access those services anytime they need them. So if someone has traveled and they fall sick out of Lusaka, out of the Copper Belt, anywhere, they'll still be able to access the service. Services are provided in a cashless manner. We do not expect a member to carry any form of cash at the time of accessing the service. So we just give a card where you have your NIMA card, and now we are even moving away from the NIMA card. We just use a thumb on the system wherever you are, and we'll be able to provide you that service. The services are provided in a cashless manner. Services, and then we cover pre-existing conditions as well. Unlike the commercial form of insurance, we cover anybody irrespective of their conditions. Doesn't matter when you come and then you say, this person is a cancer patient, they've been on cancer. And just to tell the members here, our benefits package is limitless, and access to benefits is so wide. So we cover dialysis, we cover heart surgeries, we cover all oncology cases, we cover everything that we are able to cover. It's limitless, and it's very wide. This is a diagram that shows the sketch of how we distribute, or how we are structured. Government there, the National Health Insurance Management is there, and we've also talked about the service providers that are accredited, and we've talked about the emergency transport and primary health care on the other side, and the citizens in the middle. And the citizens paying their contributions to the National Health Insurance, as you can see those arrows, and then the one arrow, the National Health Insurance paying the facilities down whenever our members get the service. So far, Chair and honorable ministers and distinguished members, this other slide is talking about the coverage in the last 6 years. We are going 7 years now. So you can see the scheme has covered 49% of the formal sector. The scheme has covered, 3 million, which is 49% of our membership. And the informal sector is 2.4, which is 39% of our membership. The elderly, that is the ones that are over 65. In our scheme, every member who is over 65 is exempted to contribute. So the 65 and elderly receive the services for free, if you like. Their membership currently standing at 6%. Then we have the pensioners and retirees as well, together with the elderly, which is 2.8. So we have about 9% thereabouts of membership on the scheme who are exempted. The poor and the vulnerable are also now about 3.2%. The poor and vulnerable are brought on the scheme. We work with the Ministry of Social Services and Community that has a database for that, and so we bring them on cover. The key successes, Chair, of the scheme in the last 6 years, we have almost already covered close to 30%. In fact, we exceeded that. This slide I'm giving is up to June 2026, so I'm sure by now. So 29% of the country's population as of June 2026 is now covered. And this has helped the country to improve the insurance uptake, because before that, the insurance uptake was only about 4%, the whole country. We heard yesterday from, again, Minister of South Africa, I want to quote, where he talked about just the few enjoying the private health insurance facilities. Now we have grown that number to 29% in terms of the insurance uptake for the population. So just to make it more clear, number two, we have registered 6.2 million Zambians, including the elderly, the poor, and the vulnerable. We have expanded the healthcare provider network countrywide to make it easy to provide an easy access for the members of the insurance scheme. We've covered full costs of care for high-cost services such as oncology, dialysis, pacemakers, and others. In the last 6 years, the numbers are huge in terms of volumes, in terms of the costs of money that the scheme has spent. Extended coverage to the poor and vulnerable on a non-contributory basis using alternative financing, leveraging on partnerships. This story, Chair, cannot be told without the challenges and hurdles that we have faced. Number one, one of our biggest challenges has been limited collection capacity against the amount of claims we receive. This is a social scheme. It's a social health insurance. It's not a profit-making insurance company. So it's a social health scheme meant to cover everyone in the country. And the collections of the scheme, based on 2% of basic pay of the limited formal sector, has been a big challenge. The high informal sector scheme utilization has been another big challenge, with low contributions and low compliance. The Zambia case, our informal sector is big, and the informal sector currently are the highest consumers of the scheme all over the country. But obviously, when you look at their contributions are low, and their compliance is also a challenge. We have had to go through a rugged journey, Chair, where sometimes we have our citizens who only pay when they are sick, and then again, when they are well, they stop paying. So when they fall sick again, they're already in the hospital. Now they want to come back on the scheme. So those are some of the challenges we face for the informal sector. Number three, high poverty levels resulting in dependency on the limited formal sector. So, Chair, obviously, Zambia, a Southern African country, like any other country, the informal sector poverty levels are still high, and that causes a problem for people to be compliant, to be consistent when making their contributions. Demand shifting is a challenge we have faced, and for those of you who are going to have the scheme, you will see this, or who are preparing to have these schemes, you will see a huge demand shift in the service utilization from the public sector to the private sector. So the moment the citizens now know that they are on an insurance scheme, and this health insurance scheme allows their members to access services from the private hospitals as well, then almost everybody is now going to the hotel of the hospital. Those who are going to the public sector hospitals, standing in queues now, they simply want to go to a private hospital where they are treated like they're in the hotel. So that is a challenge, because what that does is it defeats the principle of this public scheme to finance public facilities in order to capacitate them, improve their infrastructure, improve the drug stock levels, and so on, because that's what we do. We complement, we pay the facilities direct, but that's dependent on the claims. So if the claims are all coming, or mostly coming from the private sector, then that is a disconnect from. So those are some of the key challenges we have faced. Of course, we have found mechanisms of working on some of these challenges. Number 5, again, the cause of that is limited service availability and maybe quality of service in the public health facilities. This results in low satisfaction by the public. If they go to public facilities and they're standing in queues for a long time, or the service levels are not at the expected level, if and when they are told there's a shortage of this drug or so, then the public just decides to be going to the private sector. Chair? The key lessons that we have learned, I'll be finishing now. One is, to run this scheme, you need utmost political will, utmost. It's critical for the initiation, the sustainability, and the continuous running of the scheme. Political will from the highest level. Number 1. 2, contributions, revenue need to be augmented by additional financing sources. There's just a level to the extent which you can continue asking people to contribute. So you need to find other augmentations, other ways to augment the financing of the scheme. Public healthcare system needs to be service-ready and available for high-level scheme acceptance for people, because what happens is, as time goes, and this has been one of our lessons, people then start saying, but we are paying, so why are we not getting the service? Why are you telling me that this particular drug, you don't have it? And in the case of NEMA, what we have done is even accredit independent pharmacists outside the hospitals, so that when if a member goes to the hospital and they are not provided with any drug or something, they can still access it with a private facility or private pharmacy that is accredited. So public healthcare systems need to be ready. Number 4, the benefits package design. Our benefits package, like I said, Chair, is very wide and generous and provides almost everything unlimited or limitless. Again, some of our lessons have been that maybe benefits package design must be informed by the feasibility of financing. What is feasible? What is not feasible? That needs to come to mind time and again. We have learned that prioritize investment in public health care providers. This is something we do. So we prioritize. Our priority is first public facilities in terms of investing in them, enhance their capacity. So we work closely to see what is the need. So if this particular hospitals right now, maybe not for this, but to go into details, we give funds to public facilities, we help with their medical equipment in the public facilities, because we want everything to be up and running when the patient gets there. The informal sector is a huge challenge. for us, and we are still learning. And the scheme design rules, so we have had to do a lot of changes on the informal sector because of lack of consistency on their contributions, and so compliance is low, but then you are faced with dire situations where somebody is very unwell, very sick, life and death is around their bedside, and you cannot sometimes just say, we cannot pay because you have not been, or we cannot attend to this because you have not been paying. So those are some of the challenges we face in the scheme. I thank you very much, Chair. Thank you, sir.
I'm begging for a big round of applause for Dr. Michael Ntamati, the Director General for the Zambia National Health Insurance Management Authority. You'll agree with me that that was an insightful presentation, which covered a lot, from providing financial risk protection from catastrophic and improvement health expenditures arising from out-of-pocket payment for healthcare services, revenue pooling, strategic purchasing, reducing foreign dependency, benefits package highlights, to key successes and challenges. Thank you again, Dr. Japao. Now, I'm going to open the floor for the ministerial reflections. Ministers, you are requested to share your current status of NHI, key challenges, lessons learned, opportunities for regional collaboration. The floor is yours. I beg for your reflection on the presentation on NHI. First is the host minister. Namibia, please.
Good. Thank you very much, Chair. Good morning, ladies and gentlemen. Good morning to the fellow ministers that are here present and all the colleagues that have joined us today. My reflections are more, I have a few questions to Doctor. So he's now taken a seat, but I particularly had some questions for him based on the presentation. The first one is, so he mentioned that patients would have either a NEMA card or fingerprint sort of access that they're shifting to now. So I suppose my question then is, in a society whereby we expect that healthcare, quality healthcare is a right, what then happens when a patient presents to a facility, they need healthcare, they need a particular service, but you try with the fingerprint and it shows they've not been paying, or that they are not up to date, or they've never paid. What does, pardon me, what does that then mean in terms of the healthcare that is afforded? So that's my first question. The second one is with, or regarding the unemployed sort of population. So we know in a lot of African countries we have quite a high unemployed sort of demographic. What does that then mean in terms of the contributions? Because I read, I might be mistaken, but on the PowerPoint presentation, I had read 2% of the basic salary is the contribution. I do understand the issue of cross-subsidization, and so that I understand. But the question is to say, are the unemployed also mandated to make this contribution, or are they like the over 65 category where he said they are exempted? Or is it that the unemployed are then maybe subsidized by their okay, they're not employed, so completely cross-subsidized by those that are employed. So that's my second question. My third question is the contributions, are they limited to those that use state healthcare systems? So I know that they are, what Doctor mentioned, or what the DG mentioned, is that there are basically, or there's a system that has been built whereby you have facilities, so probably medical practices, pharmacies, and others that are pre-qualified or accredited is the word he used. So the third question is then to say, so for example, if I am a member of, just a normal member of the community, and then I decide, but I have private medical aid, I don't want to be involved in the National Health Insurance Scheme at all. Am I still mandated to contribute as a member of society and as a member of the country to contribute towards the healthcare of the rest? Then my final question, is a question / reflection. Why allow the private sector? Now, the pharmacies I understand, because you don't want a situation whereby they need to access high blood pressure medication, and there's no blood pressure medication in state, for example, because of a delayed procurement, and now they cannot access it. So the pharmacies are well understood. In terms of the hospitals, because the DG mentioned that one of their challenges is now patients, because private is an option, I will opt for the one that looks like a hotel. So I'm trying to understand, because also the private facilities, when you look at cost, they are much more expensive than what you would pay at a state facility, even as a private patient. So whereas admission in an ICU that is revamped in a state hospital might be 2,000 Namibian dollars, I'm giving a random example, media, please do not quote me. And then maybe you go to private and the same one-night stay in ICU is $10,000. So my question / reflection is it not more financially feasible and sustainable to rather say community members make that contribution goes towards enhancing the state facilities to bring them up to a level whereby there are options of private level care within the state system so that we can control cost? That's my final question. Thank you.
Thank you, Minister. Any other question or reflection or comment? Clarity? Going once, going twice, gone. Thank you so much. Dr. DG, I'm forced to request that you once again come forward to answer some of the questions. I'm sure you've been capturing the questions on fingerprint access, unemployed population, contributions, the scheme being mandatory. Yeah. Yes, please. Please, come forward. Oh, I come then.
So thank you, Honorable Minister. Yeah, I can imagine there must be many questions. But quickly, number one, the right to health is not negotiable, even on our side. And that's where the navigation between getting your population to be compliant and at the same time not denying them the quality of the right to health, those are really sensitive matters. But we found a way, with the backing of government, of course, is that there is no one who can ever be turned away from any hospital in Zambia. In fact, you will be pleased to know, and this is something government is dealing with, for us, even foreigners, access our health services for free. And that's been a big challenge. Yeah, so in our country, everybody has the right to health facilities, especially public, of course, not especially, but public, for free, public health facilities. So how do we do this? So what we do is the personnel in the facilities know which illnesses to take, even if someone is not compliant. Life-threatening can never be turned away. So those will be taken. But there are those that will be required and asked to go. We have a NEMA desk in every facility. So when that person comes or is brought and they determine that this one needs to pay, they will send that individual to the NEMA desk to do their numbers, to check their membership, and if there's anything that needs to be done, it will be done there before they get a service. But not those who are very sick. And we've had people brought who are very sick. Like I said, even in the presentation I did mention that you have to decide which ones you just have to attend to. Okay. So I hope that I've answered. And that is why, so the issue of the card and the issue of the fingerprint is important to ascertain your membership on the system. But overall, the physician must determine the position of this patient and must be attended to. Question number 2, the unemployed and their contributions. So the 2% is for the formal sector only. Formal sector. And in fact, it is 1% the employee, 1% the employer. And then they make a contribution. The employee pays 1%, and the employer pays 1% as subsidization. And the 2% then is remitted to the National Health Insurance Fund. For the unemployed, we treat them as the informal sector. And so the informal sector, we have a mechanism through which we determine your contribution level depending on the ideal should have been depending on your income. But that's so difficult to determine in some cases. So unfortunately, or fortunately for us, we use a mechanism that deals with where you stay, because then there's a rate depending on the area of your residency. So there's a rate, and so far, like I indicated in the, so if you live in the village, for example, your contributions will be way, way lower than a person who lives in the city. And if you live in the city also, your contributions will be way, way lower than if you live in high-end areas like Kablonga and places like that. So, but still, it has been determined that the contributions by the informal sector is much lower compared to the benefit utilization. I think that was the presentation I was making. Why bring in the private health facilities? Oh, that is a really complicated story, a sensitive one as well. But the major reason really is that there are certain facilities, certain services rather, that may not be available in the public sector for obvious reasons, financing and so on. So you don't want a member of the scheme to be disadvantaged. So initially, how we started was that everyone must go to the public facility, up and until if what you are looking for is not there, then you go to a private facility. But unfortunately, that has been very, very difficult to manage. And that's why I put it in the challenge, in the challenges. So it's something that we are also looking at. For all intents and purposes, we would like to do very little with a private facility for all intents and purposes. But sometimes that is a little bit difficult. Chair, I don't know whether I've left out any question, but I think this is what I wrote. Honourable Minister, is that? Okay. Thank you very much. Thank you.
DJ. Please. We still have more questions coming up. I'll give the opportunity to Minister Matsoleri from South Africa to comment. Thank you. Please.
Thank you, Minister Thank you, Minister I was under the impression that we are all going to present our experiences in one way or the other, but that not being the case, can you give me a few minutes to connect? Because in my comments, I would like to show a few graphs. That will be very, very important for me. Can I be given that opportunity? Please do. Yeah. Who will connect for me? I've got a presentation here. I want to quote from it while I'm presenting. Yeah, yes, thank you.
Excuse me. As guided by the regional director, he's saying there is a panel discussion coming later where you can reflect, Minister, you'll be given an opportunity to make your presentation. Yes, during the panel discussion that is coming after break.
Okay, thank you.
Yes.
In that case, let me keep my peace.
Thank you. Please, you can be seated.
Thank you very much.
Big round of applause again. I don't want to be the one standing between today's program and the occasion. So this marks the end of the first session, the first part of the fifth session. And now I will hand over to the program director for announcement and direction, what will happen next. Please, program director, come forward. You can clap hands for the facilitator.
Thank you very much, Honourable Minister of Eswatini, for expertly chairing that session, and indeed for the Director General of the National Health Insurance Management Authority of Zambia for sharing Zambia's experience in the arena of national health insurance. Ladies and gentlemen, I wish to just request you to give the panel, the presenters, the honourable ministers who have raised pertinent questions, a big round of applause. This is indeed why we are here, as the 5th Regional Ministerial Steering Committee for the Southern African region, not just to discuss policies in abstract, but to really get to the crux of the matters, learn from each other, from each other's experiences in country, to see how better we can cooperate and collaborate as member states to improve and to advance health security and sovereignty in the Southern African region. So with that said, I wish to just make a few announcements. We will, in a few minutes, or right now, break for tea for about 20 minutes. Now, I have been advised, in fact instructed, by the host minister, my boss, that we must stick to time. We are running a little bit behind, and so please, if we could be back in plenary to resume the next session, 20 minutes from now. Once we resume, after the tea break, we will then enter into a panel discussion which will be chaired by the Honorable Minister of Health, Lesotho, on expanding national health insurance as a catalyst to universal health coverage. So with that, it is my pleasure to suspend this session for the time being for tea break. Please enjoy your tea and see you in 20 minutes.
so much. Good morning, everyone. It looks like I also have to greet twice. Good morning, everyone. Thank you very much, Program Director. You did try to pronounce my name, and you tried really hard. My name is Mamukete Ntshege. Ntshege. A typical Sotho surname. A Minister of Health from Lesotho. And I would like to start by paying my respects to the honorable ministers here present, excellencies, delegates, members of the media, and all protocols observed. I will be chairing this second part of the 5th session of our ReSCO. And this one focuses solely on expanding the national health insurance as a catalyst to universal health coverage. Excellencies, colleagues, as you may know and remember that access to healthcare is everyone's right. And access is not measured only in terms of a distance. It is also measured in terms of money, affordability. And for us to ensure this constitutional right to every citizen of our countries, we have to ensure that we have measures in place in order to reduce out-of-pocket expenditure for our citizens, as it has already been alluded by the previous presentations. And I always believe in equity. I always used to believe equality was great, but when I got the concept of equity, I liked it more. Because if we were to stand on something between me and the Minister of Health for Namibia, if we are looking over a wall, obviously the wall might be taller for me, but for her it might just be, short enough that she can sit on the other side. So for equity, you would probably give only me a desk to stand on, while leaving her still accessing the same service. So this is what we are doing as Africa and as citizens of the soil to secure access for our people. So for this session, allow me to call the following honorable ministers as our panelists and the moderator. Honorable Minister Dr. Aaron Motsoaledi, Minister of Health of South Africa. Please welcome him on the podium. And I have here Honorable Dr. Stephen Mudise, but I have realized he is not around. So we'll skip Botswana, but Botswana is represented, at least. We'll go straight to Honorable Minister for Health, Child Care in Zimbabwe, Honorable Douglas Bombishora. Next will be Honorable Minister of Health and Sanitation of the Republic of Malawi, our chairperson of ReSCO, Honorable Minister Matarizo Baloi. And our very own host, the most hospitable. We have enjoyed your hospitality, Honorable Minister, and the Namibians, and for that we are really grateful. We are welcoming you, this panel. Please give a round of applause. A bigger one, please, for the host. And to moderate, and our moderator, your time starts from now, and as you may have already been informed, we'll be having a short presentation from Minister Dr. Aaron Motsoaledi from South Africa regarding the national health insurance. And we start with the panel discussion now. Thank you. A round of applause for me, please.
Thank you very much, Chair. And thank you for the privilege given to lead this panel discussion with the distinguished honorable ministers that we have in our region today. The topic is expanding the national health insurance as a catalyst to universal health coverage in our region. And so we'll be looking at the thematic areas, that is the governance and financing models, the equity and financial protection, lessons learned, scaling successful models across the region. I have with me, ladies and gentlemen, distinguished guests, distinguished panel, and may we, which I have to introduce to you, the Honorable Minister of Health and Child Care from Zimbabwe, Honorable Minister is there. The Honorable Minister for Minister of Health from South Africa, and the two giant ladies just next to me, Minister of Eastern Province in Zambia. No, that's Malawi. So Malawi and Zambia are just Mazoka Bwanj. Okay. Of course, same for Zimbabwe as well. Honorable Minister of Health and our chair, the Iron Lady from Namibia. May we receive our guests with a clap. I'll start with the minister who comes from Zambezi. So there's a Zambezi River in between Zambia and Zimbabwe. So, Honorable Minister, Zimbabwe has long been implementing innovative health financing mechanisms. And such as the AIDS levy and the airtime and more mobile data levies. How effective have these mechanisms been? And how is the country envisioning a pooled health fund, such as the National Health Insurance Scheme? Honorable Minister.
Thank you, Moderator. I will not go into detail about those issues which I discussed yesterday, especially about the health financing involving the National AIDS Council Fund managed for HIV and AIDS. Also the airtime, I think I mentioned something about it. But now, your last part of the question involves the establishment of the National Health Insurance. And I must say we have moved quite a bit in terms of implementing or making that a reality. I will not go into the reasons why we are doing that, because I think you, in your keynote address, you mentioned some of the reasons why. Just suffice to say, it's part of implementing what is in our constitution, that every citizen of Zimbabwe and every resident of Zimbabwe has a right to health. And what we realize as a challenge is access. And that access is limited by financial resources. Zimbabwe has a population of about 16.5 million based on the 2022 census. And we think now it's about 16.5 million. We have got private medical aid and other health insurance operating in Zimbabwe. And these cover only about 10% of the population. So the rest, 90% of the population is not covered, and they struggle to access the health services because it's out of pocket. And hence, the move to establish the National Health Insurance. So the National Health Insurance Scheme we intend to establish is going to cover every citizen and every resident of Zimbabwe. I will just mention a few differences from what you presented. For us, it's for every citizen and every resident. We see that access is denied because of limited financial resources. As a result, we think if we go the approach of saying those who are employed will contribute to this fund, there will be limitation of funds. Since I'm sure some of you from social media, you hear that there's a high unemployment in Zimbabwe. That is not very correct, because we can't have a country which is getting GDP growth of between 5 and 6% per annum when we have got an unemployment rate of 80%. These are figures which are just being thrown around by social media. The reality is that there is high informal employment. So there's a high informal sector compared to the formal sector. So if we go the route of taxing those who are employed, we will not be able to raise enough money, because those who are in formal employment are just about 20% of those who are employed. So we have gone the route of point of transaction taxation, because if we go point of transaction, we are then able to capture the informal sector. As they transact, you get a little bit of money from those products which have been identified as the source of revenue. We have had discussions with the Ministry of Finance to agree on which areas are going to be taxed. Those already being taxed, like the the AIDS levy, the airtime, we want those funds also to be ring-fenced and be part of the national health insurance. I will not go into the other details. We've got quite a lot of things that we've incorporated, and we've had discussions with the Minister of Finance, and we have agreed. Some of those areas include road tax funds, third-party insurance for cars, alcohol, cigarettes, just to mention a few. They will form part of the package to build up the fund. Now, we have identified the basic benefit package, but we're also involving public and private. The public sector, we know it has no capacity to take care of the 80% of the population alone. Already the public sector, the private sector is contributing. We've got quite a number of institutions which are run privately, and they take people who are paying cash, some using medical aid societies. But we have said those in the private sector have got to apply to join the scheme. And when they join the scheme, they can then claim money from that fund. We set up a tariff for various procedures, from consultations, diagnostics, treatment, including admission fees, which that tariff has got to be complied with by all those who opt to join the scheme. So if you're a private player and you opt to join the scheme, yes, if you're a private player and you opt to join the scheme, it means you have to comply with the tariff that has been set. So those tariffs will guide what is being charged. And you don't take cash from those who consult you, but all the cash will be dispersed from the fund of the National Health Insurance.
Okay.
What do we intend to cover? We intend to cover everything from admission, consultation, investigations, and treatment.
Okay.
I think so far we presented the principles to Cabinet and they were approved. We then went on to do national consultation with the relevant stakeholders, and we passed that. The challenges that we only faced during our consultations came from the private medical aid societies. I think they are more worried that they will be out of business. But we as government, we are not looking at business, we are looking at provision of service, especially for the vulnerable. So most of our medical aid societies, they have what they call the basic package. And for the basic package, this is for the low income earners. And they cannot access services in the private sector, but they access services in the public sector. Now, if we say everyone can access services in our public sector without paying a cent, then there is no reason for those who have been paying to the medical aid societies, because they will still access the same services for free. That's why I think we hit a snag there. So we have had our first draft of which we call the zero draft. Working together with the Attorney General, we did the second draft, and now the final draft is what has been presented to what we call the Cabinet Committee on Legislation. The next stage, actually this coming week, Monday and Tuesday, is going through peer review, and on next Friday, the ministers are now supposed to go through the peer review, and then it will be taken to Cabinet, and the bill, the next thing, will be taken to Parliament. There are some gray areas where we have left that Parliament can then polish up. The last thing that I have to mention is concerns about who is going to run that fund. In our principles, we had said we are going to establish an authority. But the others are querying to say, if you are going to establish an authority, it's also going to be an organization which is going to take money from that fund. Instead, they say we should reserve most of the funds for service provision. Therefore, this must be a department in the Ministry of Health. But when I took this to the Cabinet Committee on Legislation, there were queries to say, no. You can't run this in your ministry. We still want to, but we will know after our peer review which direction we'll be taking. So I think that's where we are. And we have consulted, we consulted the British because they've got their national health insurance scheme there. We also studied what our neighbors South Africa are doing, and we're also studying you, our neighbors Zambia, what you are doing, because we don't want to repeat the same mistakes. When we come up with our document, it must be perfect and better than what you have come up with. Thank you.
Thank you, Honorable Minister. Can we give him a clap? So there you are. We are looking for, we're expecting a better national health insurance scheme on the way in Zimbabwe, from Zimbabwe. We'll see about that, Minister. We'll see about that. Thank you. My next question is to the Minister of Health from South Africa. South Africa has one of the highest per capita health expenditure on health in Africa, and I think we saw that even in the presentation yesterday, and is in the process of about $530, and is in the process of introducing a mandatory national health insurance scheme. Of course, notwithstanding what we heard of the series of court session, legal cases that have kind of hampered it. The question is, Honorable Minister, what is the rationale for a national health insurance scheme, given that you already a highest per capita health expenditure country? Could you also elaborate on some of the key challenges faced in establishing a national health insurance scheme and what lessons other countries could learn from your experience? Thank you, sir. Or maybe we ask you to present, Honorable Minister.
Yes, I'm going to answer.
You said you have a presentation.
No, I'm going to answer your question through a presentation.
Okay, thank you.
I'll answer all of them, and hopefully time will allow that. Yes, I specifically asked for that, colleagues, because many of you might not be aware that the concept of national health insurance in South Africa started as far back as 1944. That's how long it started. And even up to today, unlike Zambia, we cannot even implement, because I've told you in court. So I'm going to give you some of the reasons why we are here where we are. The 1944, it was a commission headed by the then Minister of Health just before apartheid, Dr. Harry Lackman. Because of a problem of poor whites mainly, but also poor blacks. How do we solve that problem of poverty? And in his recommendations, he recommended the establishment of national health insurance, which means the whole scheme is not only about health, it's also linked with development and economy of a country. Unfortunately, as you know, the history of South Africa, when they were still studying, and they were going to start with a few clinics, because the national health insurance, which is not based on primary health care, will collapse, even ours. Any country here that's going to run a national health insurance and is not basing it on primary health care, it's not going to be sustainable. Even the British knew that. After 77 years of running NHS, they've now moved last year to start implementing primary health care. So in the case of Dr. Harry Lackman, that was actually going to be the position, but as you know, 4 years later, the National Party took over, apartheid started. And the word universal health coverage and apartheid cannot be found in the same sentence. That's how it died, a natural death. Until 2007 in the conference of the ruling party, where we then said national health insurance, and we started with the act. Now, I'm going to, I believe here, our aim is to share with each other. Because if we do it per individual country only and believe we'll win, that's not going to happen. Because the whole region is integrated And I'm going to show you how some private healthcare services in South Africa are destroying the neighboring countries. And I hope I'll be able to do that within the given time. Now, let's start here. The World Organization has long established that there are six building blocks to a healthcare system anywhere in the world. And they are there on the screen. If your healthcare system lacks or is weak in any one of those building blocks, the population will feel it. They may not know that this building block is weak because they don't know the building blocks. Now, as you see, number 4 there is in red, because the World Organization established over ages that regardless of resolutions we take in health, they will never be implemented if we don't solve number 4, health system financing, which the National Health Insurance or Universal Health Coverage is all about. Now, I put the Alma Ata Declaration there for you not to forget. In 1978, in Alma Ata, in the former USSR, how health was defined and what is wrong with the healthcare systems of the world. And that even far back then, there was a slogan called Health for All by the year 2000, which dismally failed. When the Alma Ata conference was held in 1978, I was doing first year medicine, and we were excited by the prospect of health for all. It never happened. In fact, it reversed in most parts of the world for the reasons I'm going to show you. So the universal health coverage is an attempt to go back to 1978 for health for all by the year 2000, which we have failed to implement. And the World Organization is arguing that the reason that we couldn't is because healthcare system financing has not been fixed. So you can call slogans of health for all, equity, equality. If you don't have a means to do so in terms of healthcare financing, you can forget. Now, colleagues, there are only 3 methods in the world to finance healthcare. There's no other. If any colleague comes with a 3rd method, please tell us so that we include it. But we know only 3 methods. And I want to show where Africa is placed in those 3 methods. But before going there, this statement was put in one of the South African newspapers, Daily Maverick, in June last year by Professor Robert Yates. He is the professor of health economics in the London School of Economics, health economics. He said South Africa should ditch its American healthcare system. You can replace South Africa there with many of our other sister countries. What did he mean by a American healthcare system? The healthcare systems that we're all clamoring for, which we are all running in some of our countries, are American in style. And that is the worst form of healthcare system you can ever have, where there's a lot of money, huge amounts of money, but that money never reaches patients. It never, in other words, it's not money that goes to patients. It's money that goes to people who run the system. And that's what Robert Yates said. Dr. Margaret Chan, who was the DG before Tedros, actually confronted me. He said, Minister, the healthcare system in South Africa is British. And I think in most of the countries here, because we're all British colonies, the healthcare systems we are running is British. The nomenclature, the curriculum, everything is British. She then said, running a British healthcare system, at what stage did you become American in terms of healthcare financing? Because the financing of health in UK and America are completely different. And for some reason, because of the power of America, we've adopted the American healthcare system. That's what most of any private sector, whether you find it in Zambia, South Africa, Namibia, or what, the private sector will be running the healthcare system. That's American in nature. I just want us to know that, whereby the money doesn't go to patients. Now, I think, allow me to share this with you because it also affects all of us. This was done in 2009 by the World Health Organization. It's called National Health Accounts Data Set. In other words, of the three methods of financing health, where does each country stand? Where are we? Where should I point? Okay. Yeah. As you can see, the three methods of financing health is the blue bar. It's called mandatory payment of health. Zambia said so, that your healthcare system is going to be mandatory. Yes. The second one is voluntary prepayment of health. This is the one that is called medical aid, which is predominant in South Africa and many other countries, and is the worst form of healthcare financing. That covers a few people. The last one is out of pocket, where a patient is supposed to pay cash, like you are in a supermarket. There's no article you will pick in a supermarket for which you won't pay, definitely. Now, out of pocket or cash is that there is nothing you can get in healthcare except if you put something from your pocket. Now, where do we stand? This is what Professor, the flags have blocked me. Professor Yates was talking about. If you look at the end of those graphs, these are developed countries in Europe, but on the extreme right, you see two countries there, South Africa and the US. Our healthcare system financing is more or less the same. The predominant method of financing health is that voluntary prepayment. And the World Organization declared South Africa and the US as outliers that were lying out of the realms of what other nations are chasing. Because we are, as I said, South Africa is running a healthcare system. Now, I thought it's important for you to see this. In 2009, the World Health Organization declared Africa a disaster in the making. Yes, we are a disaster. And the grounds of being declared a disaster is what you see on the screen there. Because the predominant method of healthcare financing in Africa at that time is that green. What is it? Cash. Yes. It's out of pocket. You have got to get money in order to get health. If you don't have money, forget. Now, there is something interesting there, Minister of Namibia. If you look at the screen there are some sore fingers pointing upwards. Yes, voluntary prepayment of health. It is South Africa and Namibia. Okay. That's medical aid. I told you yesterday that Namibia is using South African medical aid. Okay. So we've infected you with a very dangerous disease there, which I was happy your president is trying to deal with it. But if you check, look, let me be open without you labeling me as attacking countries, because I want to show you realities. If you see at the end there is Sierra Leone. Yeah. Yes. The whole thing is green, 90% green. Means you need cash there. It explains what happened in 2013. Next to it is Guinea. And the Liberia is somewhere there, not far. It explains what happened in 2013 when Ebola struck that country. Okay. It spread for a long time without anybody noticing, because nobody will go to look for health care because they need cash first. Yeah. Okay. And that's how Ebola spread. So it actually explains some of the phenomenon we've seen. Now, will Africa remain like that? And I'm happy that we are getting out of it. If we all introduce universal health coverage, we're all going to be blue there. Oh my God. Yes, so universal health coverage. I was just giving a history of countries that have got it already. Now, this is what I was telling you about yesterday, and I want you to avoid that. Whereas the World Organization said countries must use 5% of their GDP on health, South Africa is already at 8.5%, which is 570 billion rand. That's a lot of money. That's not the budget for health, colleagues. It is what we are spending, expenditure on health. And what is wrong? 51% of that goes to only 14% of the population. And the remaining 49.86. Who is the 14%? Those are the people there. The cream a la cream. That includes me, by the way. Members of parliament, yes. And we are being subsidized for 70 billion and getting tax rebates of 33 billion. All this money should be running universal health coverage. But it's not. It's not. And I also just want to indicate this to you. Spending a lot of money in health does not mean universal health coverage. It does not mean that, definitely. There are BRICS countries, the original BRICS. As you can see, number one there in expenditure is Brazil. They are spending 9.89% of their GDP on health. Number two is South Africa at 8.5%. We've overtaken Russia and China. India has not even reached 5%. But why am I showing you that? Let's look at health outcomes as indicated by mortalities. Those will be shown by the rate. As you can see, all of them are on South Africa. We number two, but yeah, everything, child mortality and all that and all that. Now, just give me 2 more slides, sir. Okay. Now, here, I also want to show you where it can go wrong with money. And I picked that up on the Zambian presentation, if you don't control prices. This shows what happened in South Africa in 2010 and 2022, where the money of insurance went to, of medical aids. As you can see, huge amount of money out of 84 billion collected in 2010. Huge amount goes to private hospitals, as you can see there. And GPs who are providing primary health care get very little. On the red there, I also want to caution, is what is called non-health. Non-health are people who are not providing health. They push paper, write invoices, write all that. But in South Africa, they were getting a lion's share, more than even doctors themselves. If you compare, even in 2022. Now, here again, it shows you can run a democracy, but still apply apartheid rules. What you are seeing there is South Africa in 1960. Those are the first set of graphs. South Africa in 1960, the black shows private health care, the blue show black. As you can see in 1960, most black people will be in public and the whites are in private, if you see there. If you go to public, it's mostly black and whites are very few. Fast forward 2015, the graph hasn't changed. You still find whites in private and blacks in public. Why? Because the levels of poverty have not changed. You know? Now you, Minister, you said 10%, yes, are covered in Zimbabwe. In South Africa, black people who are under medical aid are only 10% of the black population. But in the white population, it's 72%. 72% are covered. That's why the parties which have gone to court are mostly whites, to protect that. Because it's 90% of blacks who suffer, but among whites it's only 28%. And they don't want us to change that. Now, I begged for permission from my sister there from Lesotho to show you this. This report is from the World Bank. It shows 65 countries around the world and how much money they spend on health. As you can see there, on the mountain, on top of Mount Everest, at the top there, is US. It's spending 22% of its GDP on health. That constitutes 43% of global healthcare expenditure. All of us, Europe, Asia, Africa, Australia, all of us added together, we constitute 57% of total expenditure. 43% is in one country, that's the US. And my suspicion is that's why Trump has done what he has done to us, because they told him where the money is going to. Now, the middle red line is the average for European countries, which I told you is 10%. Now, the red vertical line there is South Africa. Now, if you check number 1 at the top is the US. Lesotho is number 5, madam, meaning in terms of healthcare expenditure, Lesotho is number 5 in the world. Just 5 from the US. What has happened? It's not Lesotho that has caused that, because I also want to advise. There is this issue of PPPs. working together with private. NHI doesn't mean you ban private practice. But one of the biggest private healthcare hospital groups in South Africa went to Lesotho in what they call a PPP. Made them to take your biggest hospital, Queen Elizabeth Hospital. And it was it was renamed Mamohato. Because, yes, Nedbank told Lesotho when they were cheating us, said, no, Queen Elizabeth is colonial, give it under your own king. And the queen was Mamohato. But what happened is, there's no way Lesotho can afford that hospital. It's extraordinarily expensive. Why am I showing you this? Because unless, when you establish NHI, unless you form a pricing committee, that must determine prices for both public and private. If you allow private on their own and say, we'll just send people to private, everybody will go there, and you won't be able to pay for it. So there has to be a pricing committee so that people can go to public or private, pay the same money. Yes, pay the same money, why not? In South Africa, we have calculated, if you want to do a circumcision and you go to a GP, in Soweto or in any township, you'll pay 2,000 rand for a circumcision. But if you go to a private hospital, you are going to pay 18,000 rand. That's a fact, and those figures have been established. Because what are they going to do? Why 18,000? A circumcision can be done by a doctor. Like me, I've got a junior degree. I'm not a professor. But in the private sector, they are going to look for a urologist, an anesthetist. They are going to look for all the big guns. A professor of urology who trained for 13 years is going to be doing a circumcision. So that, So we are going to abolish that. Now, I also want to show you the pitfalls. In South Africa, we have lost the aerial battle. The whole media and most of the public are against us because we have lost the communication to the public. It has been won by those who are against universal health care. And I want to give you an example. This place is called Lusukisuki, next to Port St. John's in the Eastern Cape. They didn't have a clinic. They hired a clinic from Metropolitan Life. The MEC there did something terrible. We have got the provincial ministers called MECs. After differing with Momentum, he told them to go to hell rather than pay what the rent he wanted. They agreed to go to hell. And they did go, but they took their building along when they went to hell, and there was no building. And out of panic, these tents were put to run clinics, as you can see. One of the most powerful daily papers in South Africa went to this place, photographed these tents, and at the bottom there, and we're just starting to put the NHI Act together. At the bottom there, it was written NHI Clinic. That when your minister talk about NHI, you must know that this is what he's talking about. How can you then be followed by the public? Said, no, this is NHI Clinic. If you don't understand NHI, just look at these tents. We try to fight, you won't win that battle. Then we went to Lisigi. This is what we put to replace those tents. It was never, yes, you can cheer, but it was never shown in any media up to today. It was opened officially by the president, but no media showed it. They keep on showing the tents up to today. And that's why we are going to lose the battle. This is what it looks like. Now, yes, now NHI, now why did we do this? You have got to find somewhere to compete with the private sector. Otherwise, they'll beat you. They'll beat you and your members of the public will go along. Now, we wanted to demonstrate with that because this is what we did in 2010. We established the world's biggest HIV counseling, testing, and treatment campaign, and maternal mortality dropped from 2010 there, as you can see, at the peak, right to the bottom in 2019. It only went up because of COVID. Why am I showing you that? Because the HIV/AIDS program in South Africa is run like NHI. It doesn't matter how rich you are, whether you have got medical aid or what, as long as you are a human being, you test. If you are positive, we put you on ARVs. If you get complications, we treat them. And that's what we could achieve. And we believe we want to do that for all the diseases. Now, what are the problems that you are going to experience? Sir? Because they are going to take you to court also. Yes, at the moment, I don't wish it, but I'm not hoping for it. Because, no, I'll tell you, in South Africa, the powerful private sector is also in your countries. And they don't want anything that is successful there. So what are the issues in court? It's an issue of multi-payer system versus single-payer system. If I understand, in Zambia, you are doing a single-payer system. Multi-payer system is allow medical aids to go on, put NHI for the poor. And you know what will happen if you separate the rich and the poor. Those who are rich will just go to one side, and the poor will be on the other, and they won't be able to win. But this is one of the issues in court, that if you allow NHI, allow us a multi-payer system, so that those who are rich can choose us. But what about the poor? Now, countries that started the multi-payer system because of pressure are there on the screen. I can tell you all those countries are now scuttling for a single-payer system. They want to go back because a multi-payer system has not worked. Some of them have done it for ages, hoping it's the best system. Now, there are a few quotations there that are important. One is from Professor Robert Yates, London School for Economics. He said, market-driven, privately financed health system do not result in universal health coverage. This does not rule private sector administration or provision of services, but it means when you put up the money, because this is about money, it can't be private, it must be public, and they can use it to go to private if they so wish. Then you have got the former Prime Minister of Norway, Gro Harlem Brundtland, who was also a Director General of the World Organization. She said, if there is one lesson that the world has learned, it is that you can only reach universal health coverage through public financing. Any other form of financing, forget. The other issue that is in South Africa that made us lose the battle is affordability. Can you afford, as you are dreaming, to provide good quality health care for everybody, regardless of their economic status? And their answer is no. They are saying this NHI in South Africa will cost 1.3 trillion rand. These figures are even quoted in court, and they say they are from Momentum Life. We confronted Momentum Life. Let me tell you what they did. I even called it publicly mathematical hooliganism. Let me tell you what they did. They took the average of what a person pays in a private hospital. What's the average if in South Africa you go to a private hospital? How much will you be charged on average? They took that figure, multiplied by the population, and came to 1.3, meaning everybody will go to private health and pay the same prices that are there. That's why we need to be very careful about that. The other issue is corruption. They say this is going to be a corrupt scheme. And anyway, I don't have to debate that. But I want to finish with this. The terms that are being bandied around. There is something called risk equalization fund, where medical aid says, as Zambia has shown, the aim of the scheme is social solidarity.
Honorable Minister, my apologies. We're running out of time, and if you could please wrap up in about 2 minutes.
Yeah, this is my last slide.
Yeah,
My dear. You just came on time. This is my last slide. Yeah, there's something called risk equalization. Because Zambia said the aim of the scheme is the rich must subsidize the poor. The young must subsidize the old. That is the phenomenon. But it doesn't happen like that in practice. When people join, they don't say, we've got enough poor here, They just join. Then you are supposed to put a risk equalization fund, pay those schemes that seems to be having very many old people or many sick people. But that it's not necessarily in NHI, because you are equalizing everybody already. Then there is low-cost benefit options, which are winning in South Africa, and I suspect they are going to spread them in the whole region. Low-cost benefit options is where You join a medical aid, you pay very little, very, very little, and you think you are covered. The day you are sick, they tell you that we can't pay for this. We can pay for flu. We can't pay for surgery. We can't pay for this unless you are in hospital. You must be admitted first, etc. Many young people in South Africa are no longer joining medical aid, but are running for these benefit options in large numbers. As we said, and the last issue, they are offering South Africa that everybody will be on medical aid, provided we allow the low-cost benefit options. There are no low-cost benefit. There are low-cost, low benefits. And the price will be carried by the national, because anybody who doesn't survive there, by the public, will come to the public healthcare system. Thank you very much. I was right when I said it was my last slide.
Ladies and gentlemen, there you are. There you are. Honorable Minister, thank you very much. That has been outstanding. Absolutely. By any degree. At least we've learned something. Mathematical hooliganism. We wish you well, sir, in South Africa to ensure that the National Health Insurance Scheme comes to light one day, irrespective of what you're going through. Thank you very much. With that, and given our time now, I'll quickly go to Namibia, and the minister seated to me, next to me just now. Minister, I'll have a question for you. And for 5 minutes. Is it okay? We'll give you the...
Yes, it's okay.
You are the host, so you will have the time. In Namibia, how are public funds channeled in the provision of healthcare by both the public and private sector? What financing reforms would drive both equity in access and financial risk protection?
Okay, so the Namibia case. So under 5 minutes, I will try to be as brief as possible. Firstly, the Minister of Health of Zimbabwe was saying his UHC system will be the best, but he's further along than I. So we have not gone to cabinet yet. We are yet to take it to cabinet. We are yet to, so I think Namibia's will be the best because I'm learning from all of the countries. So with that said, really, Namibia, so two things, right? There's the Abuja Declaration that requires that countries now spend 15%, right? And make sure that that is dedicated to healthcare. Namibia has met the Abuja Declaration, quite all right. But there's the other side, which is also sort of prompted by another statistic, because according to WHO, at least the recommended out-of-pocket is not more than 15%. Namibia is at 8%. So generally, Namibia seems to be doing quite well, right? Now, there's the other side of things. I like, when I've gotten to know my ministers of health, so I know that at least when South Africa speaks, I can be very diplomatic because he is very, what is the word? Very artistic, honest. Somebody said honest. You're a true politician. He's very honest. So there are a lot of similarities that exist between Namibia and South Africa. And then I think I see a lot of my top leadership in the ministry here, and I think they will be able to tell you there are a lot of similarities that exist. Why? Because Namibia spends a lot on healthcare, but we would hope that the outcome is much better than it currently is. So that translates to what the minister said when he said spending a lot on healthcare doesn't necessarily guarantee good outcome. So now that's the conversation we need to start having, and it's not a famous one. It's really not. The crux of the matter here is to say that similar to South Africa and a lot of other countries, Namibian healthcare system, twofold, right? You have that public of which 85% of the population is footed on the bill of government directly. And then you have that little 15% that is relying on sort of the private sector, but mind you, the greatest population is this 85%. So the conversations we need to start having is to say, how do we need to redesign healthcare? It might not make people comfortable. It might not make a lot of people comfortable. My comment is always to say, get the professionals that understand the systems, that know exactly how we need to restructure and reform, get in the health economists to come in and restructure the system so that it begins to benefit the masses and not just that minority part of the population. Now, it's not going to be a popular thing to say. Because people don't want to be uncomfortable. The system has run the way it has for a very long time. Luvinda, why are you coming to destabilize things? So get in the experts, get the health economists in, restructure it the way it should be restructured so that it can start to benefit the masses, no matter how uncomfortable it is. Namibia is currently, Namibia is currently going through that restructuring process. We are currently working on the Universal Health Coverage Bill. And the reason I said ours will be best, I said it as a joke, but that is why these conversations are so important. Because we don't just want to come and talk and go. We want to come, have conversations that have actual tangible outcomes. The Minister of Health, Zimbabwe, and I were talking, and we were saying, by next week, we're scheduling that first meeting where, led by the ministers with the technical experts, we want to ensure that by the beginning of next year, we do that first pooled procurement and stop just talking. So similar to that with the UHC bill, this is an opportunity, and I was speaking to my DED, Dr. Kandetu, to say, let's listen, let's grab what we need to grab, and make sure that when we put out that bill and when I take that bill to Parliament, we have the best of all the worlds coming together to build a stronger healthcare system. Thank you.
Thank you very, very much, Honorable Minister. That was outstanding. So one takeaway there from both ministers in South Africa and Namibia: more money does not necessarily mean more outcomes. In fact, the money ends up going to people, companies, and not the patient. Thank you, Minister, for that. We really appreciate. I quickly go to my last question, my last minister, Minister from Malawi. Minister, in Malawi, what challenges is the country facing with regard to sustainable domestic financing for health? And is a national health insurance scheme feasible in the Malawian context? Your comments.
Thank you so much. First of all, let me just applaud my brother, Dr. Aaron, for a very, very artistic presentation, but worth it. It was artistic, but worth it. It's been one of my highlights for this event. Talking about Malawi and the issue of domestic financing, Malawi is taking deliberate steps to ensure that, operating in a dwindling environment where resources are dwindling, it's important that Malawi develops its own base just to ensure that issues of health, they're number one. And I would say that there's a lot of political will there, because we've seen just a few months ago, we've been able to launch the National Health Fund, which is the first of its kind for the country, just to show that the political will can be able to drive the health outcomes that we want. And also, we've seen an increase in the budget allocation, like in 2021, where the health budget was around $147 million, and right now for the 2026-2027 budget to 210, even though we're not yet at Abuja declaration, you know. We're still working towards that. But then for a country that has been depending on majority on external donor support, there are always challenges. And one of the greatest challenge that is there is how do we sustain, how do we make sure that there is sustainability? You know, all this, we're talking of the National Health Fund that has just been established. Yet the resources we are talking about that they are dwindling, they are going down each and every day. How do we make sure that we achieve universal health coverage amidst all this? And then there are also some unforeseen challenges like climate change. We are in a space where if in the health sector, if we overlook the climate aspect, which is affecting us, bringing climatic shocks now and again. We're battling with cholera, mpox, and then you look at right now the issue of El Nino. We are already planning for that. It has effects on health. So those are some of the aspects that keep pulling us backwards when it comes to mobilizing a lot of domestic finance. But coming to the question of establishment of the national health insurance, as a country, we believe that the first goal is to ensure that universal health coverage is achieved. And there's also an issue of rights, where every Malawian has a right to health. So we are doing just like the other countries, we are doing much learning, especially through this platform. We're learning as much as possible, but as we're learning that, there are aspects that we are putting in place, reforms that we are implementing as a nation, like I talked about the establishment of the health fund. It means it's a platform because we don't want to establish something that would be running parallel to the systems that are there, but we want to establish something that is sustainable and something that would not shrink or provide or constrain the already fiscal space, already constrained fiscal space that is there. So apart from the establishment of the health fund, we're also making sure that we are strengthening the primary health care service provision. We want to make sure that every Malawian has access to
development partners, delegates, and all stakeholders whose invaluable contributions ensured that the successful convening of the 5th Southern Africa Regional Ministerial Steering Committee ReSCO meeting adopted in Windhoek, Republic of Namibia on the 21st day of August 2026.
Thank you so much. Let us give another round of applause. I now request the member states if there are any comments. If we indeed agree to what the Secretariat has put together to mean what we have discussed or what we have done or what we have achieved during the 2 days. Are there any comments before we endorse? I see no comment. It means all the member states don't really have a comment. Let's get into the endorsement. Can we have countries, member states endorse the Windhoek commitments? These are the commitments that we ourselves have made. Can we endorse the commitments, please? Namibia endorses. I see Zimbabwe, South Africa, the Kingdom, Eswatini. I see all the countries. Malawi is endorsing. Let us give a round of applause. Thank you so much, ladies and gentlemen. This marks the end of the closing session on Windhoek commitments. Secretariat. All right, I've just gotten guidance on the next item on the agenda, which is looking at who wants to host ReSCO next year. We understand that Namibia has set the bar very high, but we know other member states will also do exceptionally well. So who is ready to host next year? We are happy with all the African experiences. Who is ready for next year? By show of hands. Okay, you can put it up. I see Botswana. So that's just a proposal. I'm not declaring. I'm not declaring. So far, we have Botswana that has showed interest. Any other country? South Africa is supporting Botswana. Okay, okay. Zimbabwe is supporting Botswana. Oh, actually everybody, Mozambique, I see Eswatini, they're all supporting Botswana. Secretary, do I declare? Oh, wow. It is my humble duty this afternoon to declare Botswana as the next host of ReSCO next year. A round of applause. Thank you so much. I know it's been a long 2 days, much as today it's half day, but I know we're looking forward to lunch. The energy levels have gone down. We are finally here. We have finally concluded on the sessions that we had on the agenda. And as the chair, Your Excellencies, honorable ministers, distinguished delegates, ladies and gentlemen, allow me to offer my concluding remarks. I know we would have loved to be here for 1 or 2 more days, but there has to come a time where we have to go back and finish what we left off back home. Let me begin by reiterating what I said in my opening statement. Southern Africa has everything it needs to build health systems that are stronger, more resilient, more innovative, and increasingly self-reliant. We have the people, institution, we have the knowledge, we have the market. We have everything. We have the political will to work together. Our opportunity is therefore not simply to respond to today's challenges, but to build the health architecture that Southern Africa will need for the next generation. As my sister from Namibia said, health leadership knows no borders. If a citizen falls seriously ill whilst in another country, should a border determine whether that person receives timely and quality care? Obviously, the answer is no. It shouldn't. We must deepen cross-border cooperation, referral systems, information sharing, emergency preparedness, and health workforce collaboration. We should move from thinking of health systems as a national island to thinking of Southern Africa health as a connected regional system. If disease crosses borders, our surveillance must cross borders. If patients cross borders, our referral system must immediately respond. If health workers move across borders, our systems must cooperate. Our beloved President, Her Excellency Dr. Netumbo Ndempelila Nandi Ndaitwah, has challenged us with a very critical question. How far have we moved from commitments and aspirations to systems that truly deliver for our people? We need to make African healthcare to be sufficient for Africans. This is not about turning away from international cooperation. It is about building a stronger African capability so that partnership becomes a source of strength rather than dependency. Our partners have contributed enormously to African health, but the most successful partnership is one that leaves behind stronger institutions, financing systems, supply chains, research capacity, and national ownership. We must also be clear about financing. Private financing has an important role in bringing the much needed capital, innovation, technology, and efficiency, but private financing should not complement the public investment required to guarantee universal access. Public financing must remain the anchor of equitable health care. As President Dr. Netumbo says, no citizen should be denied quality health care because of geography, income, or social status. We must therefore strengthen domestic public financing, improve public financial management, and ensure that resources approved for health actually reach the front line. Ultimately, our people do not experience budgets. They experience whether the clinic has medicine, whether the health worker is available, and whether the patient receives the care that he or she needs. The communique rightly places domestic public financing, financial protection, and stronger public financial management at the center of sustainable health systems. We also have an extraordinary opportunity to build Southern African health ecosystem. Why should Africa remain a major market for medicines, vaccines, diagnostics, and medical technologies without becoming an equally important producer? These are some of the questions that we need to ask ourselves and begin to bring out answers with actions. Let us therefore move beyond simply procuring from one another. Let us manufacture for one another. That is how health will become an engine of industrialization. We must also deepen research and accelerate interventions. Our universities, scientists, clinicians, entrepreneurs, and innovators must become central to the future that we are building. We need African evidence to answer African questions. What financing models work in our communities? What technologies can we develop locally? How can research translate more rapidly into products and services? The Southern African Directors of Planning and Policy Forum and the Health Economics, Financing and Public Financial Management think tank provide an important foundation for African-owned evidence and policy capability. Fellow honorable ministers, the question therefore before us is no longer whether we have made the right commitments. The question is how far we will move from the commitments that we've made today to implementation. A communique is important. A strategy is also important. But ultimately, the citizen must experience the difference. Your Excellencies, honorable ministers, we should leave Windhoek with confidence, not because the challenges are small, but because our collective capacity is greater than the challenges before us. Let us build a Southern Africa where no citizen is denied quality health care because of geography, income, or social status. Our vision must be bigger than protecting individual national health systems. Let us build a Southern Africa health system that is connected. Let us build a system that is resilient and also a system that is innovative and completely sovereign. Let our borders facilitate cooperation rather than restrict care. Let public investment guarantee equity and private investment accelerate innovation. This is the Southern Africa we can build to become a region defined by what we can create together. A region producing solutions, a region that can contribute in shaping the global health system. Our challenge is significant, but our opportunity is greater. Let us move from aspiration to implementation, from national thinking to regional action, from consumption to production, and from fragmentation into integration. Because the future of Southern African health security should not simply be secured for us. It should be built by us together. And then, when we build it together, we will not only create healthier people, we will create stronger economies, stronger institutions, stronger communities, and a stronger Southern Africa. Lastly, but not least, Your Excellencies, let me take this opportunity to thank my sister, the Minister of Health here in Namibia, for the hospitality. We will never thank you enough. Everyone will keep thanking you, but we felt at home, and we know we'll continue to feel at home as we progress with the day. Let me also take this opportunity to thank Her Excellency, the President of the Republic of Namibia, for hosting us. Thank her for ensuring that he's been part of us and she's been with us. Excellencies, distinguished guests, I wish you nothing but the best. I wish Southern Africa the best. I wish you, as you travel back safely, I wish you all the best. May God bless us all. Thank you so much. Secretariat or MC?
Thank you, ReSCO Chair. Good afternoon, Honorable Ministers, Excellencies. I see Dr. Kasea is not in our midst. Is there anyone delivering a message? Africa CDC? No? Thank you very much, Chair ReSCO. And at this point in time, it's my privilege to call the ReSCO Vice Chair and the host minister, Dr. Esperance Lovinda, for your closing remarks. Honorable Minister, you have the floor.
Good afternoon, ladies and gentlemen. My goodness. You might as well say, please get off, we're done. Good afternoon, ladies and gentlemen. I will be fast, I promise. It's Friday, by the way. I am happy, genuinely, deeply happy. I am content. Shame, I know I put my team under a lot of pressure. I'm a perfectionist, so I'm never satisfied. But please, ladies and gentlemen, help me by putting your hands together for all the organizers. Please put your hands together for them. The past 2 days have been intense, they've been productive, they've been thought-provoking. So many outcomes have already started. The ball is already rolling in the background. There are key action items, there are key meetings that are already being set up. There are new ways of thinking that are being adopted. There are new partnerships that have come from this particular meeting. And I'm deeply humbled because my main goal was to say, I do not want us just to meet to pass time. The people sitting in this room, I would literally say, are the leaders of healthcare in Southern Africa. And so for every single one of you to have left your workstations, not just the ministers, but all of you, the executive directors, the permanent secretaries present, all the senior leadership, the experts, we do not take it lightly. We know that it was a sacrifice for you to take time out of your schedules to be here. But I'm comforted by the fact that indeed we have reached what our target and our aim was. We convened here with a clear mandate. I trust and believe we have achieved that mandate. In areas where we have not, the path has become much more clear. Being here, listening to stories from the other ministers, I'm sure all of my ministers can say, we've all taken mental notes to say, this is something we can consider in South Africa, in Zimbabwe, in Namibia, in Malawi, in Lesotho, in Botswana. And that is ultimately the goal of this gathering. We have addressed the need for sustainable domestic financing. We have recognized the truth without sugarcoating it. I won't look at a particular minister. I am incredibly proud that Namibia also took this historic step to sign the Africa Pooled Procurement Mechanism with the Africa CDC. That in itself is monumental. The adoption of the Windhoek communique moments ago solidifies our shared resolve. We look forward to gathering in our sister country, Botswana, next year, where ministers will be able to report on progress, because we are accountable to you. So the minister sitting in front here, I always say it's actually the reverse, because the people in front should be you. Because the ministers are ultimately accountable to every single one of you in this room, to every single citizen and community member from our countries. So we are merely but the servants. I want to take this opportunity to extend my deepest gratitude to my big brother, His Excellency Dr. Jean Kaseya, for his visionary leadership at the Africa CDC. I take the opportunity to thank the World Health Organization Director General in absentia, Dr. Tedros. For those of you in the public health world, which is all of you, know how significant this next year is for Dr. Tedros, of course, at the World Health Organization. And so his presence is not one we take lightly. It truly is a culmination of his leadership in healthcare and how much he values the healthcare of Africans. To the Africa CDC, Southern Africa Regional Coordinating Center, the RETAC members, the hardworking team from the Ministry of Health and Social Services, the Ministry of International Relations and Trade. When I mention my team, I always forget to mention someone very important. So if you see me and you see anything really working in my life, I always say, you know, when someone tries to book a meeting with me, half the time I don't know if I'm available or not. That is how detached I have become, because at any given time, there's so many things happening. So I want to use this opportunity to thank my personal assistant, Rejoice. Please put your hands together for her. So we are who we are because of the people behind the scenes. As we depart today, I hope you take with you the strategic commitments that we have made. One of the things I also sincerely hope is for some countries where borders existed, not the normal borders we know, where those borders and boundaries existed, even in our minds, where we couldn't pick up the phone and call the Minister of Health Namibia and say, but what are you doing for this and this and this? I'm struggling with this. Or Namibia to call and say, but how did you get this part right? I sincerely hope that those boundaries have also been broken with my fellow ministers, and that we will work together to build the healthcare system in Southern Africa that we all desire. With that said, ladies and gentlemen, allow me to wish you safe travels to your respective countries, and thank you very much for attending. God bless.
Thank you so much, ReSCO Vice Chair. Thank you very much, Chair. Honorable Ministers, you have adopted the Windhoek Declaration, the communique setting out the commitments. And in the very words of the ReSCO Chair, the declaration is about advancing health security and sovereignty by moving from aspirations and commitments to actions, time-bound actions. And it's such a pleasing coincidence that next ReSCO happens just in our very neighbor, so next door. So we can compare notes, Botswana, on some of the aspects that you can do better. Thank you so much. And of course, from our side, administratively, it has been an absolute honor to serve the 5th ReSCO to the extent we can, and the best is yet to come. And this best would also happen in the afternoon. The VIPs, VVIPs, honorable ministers, the host minister, Dr. Esperance, has invited you to extramural, loaded extramural activities that are coming up. Your liaison officers would provide the specific information. Because now it's fun-filled, before you get to the implementation, to charge us with the implementation of the actions. So because the extramural activities are what they are, as the name denotes, so we should have the gear that is fit for purpose. So Honorable Minister whispered to me that you can have maybe something like 25 minutes or so, just to get to the gear, Minister Aaron. There might be football, there might be, you know, Bafana, Brave Warriors type of thing. You know, chase a lion or something like that. So let's just get to the gear that is needed. The liaison officers will provide the information so that ideally by 1300 hours, we could then head to those spots. There will be lunch provided where we are going. I know that 13 hours here, lunch would also start, but there would also be lunch where we are going. The ministers would be going. So by 13 hours might be appropriate so that we manage times and the fun-filled activities really are put to use, and there is value for money and the quality of outcomes, as we say in the health sector. Having said so, we are then signing off. Concluding remarks have been shared. Let me therefore, Honorable Ministers, Chair, Vice Chair, ladies and gentlemen, request that we rise to the singing of the AU anthem and the Namibian anthem, and we are done. Thank you. Thank you so much, High Table. We see you off. We support you. We are together. Let's allow the High Table to depart the venue, and we follow through. Thank you so much, everybody, for rescuing the day. Secretary, I stole it from